Next slide. If you have not already done so, I think a couple of people have, but please feel free to introduce yourself in the chat. Drop your name, your role, organization, and if this is your first echo session. Again, my name is Lindsay. For those of you all who are just coming on, I am with TDH and I am the Hepatitis C Prevention Director. We'll give people just a couple of minutes to do that real quick. If you do have any technical issues during the session, please do not hesitate to reach out to Kimber Miller. She did drop her information and contact information in the chat as well. If there are any registration issues with the continuing education approach, please reach out to Claire Bowles. I'm not sure if she is on here just yet, but we can drop her information as in the chat as well. Okay, Kimber dropped the information about the continuing education through Southeast Asian Education Training Center. So just in case you do have any issues. We'll go ahead and we'll move forward with our presentation. Again, it's on the primary care approach to HCV workup within the pediatric population. And is Dr. Alfaro Cruz here yet?
Yes, I am.
Okay.
Okay, good afternoon, everyone. And we are already in February, which is awesome because that means that January, it's done. So today, I'm going to talk about the primary care approach to hepatitis C workup in the pediatric population. Now, if you have any questions, I know some of you may be more on the adult side, but if you have any questions regarding pediatrics or even those adolescents, I think this will help us a lot too. A lot of information that we'll talk today sometimes can actually cross with the adult world. So let's kind of dig in this. Please, next slide, please. I have no financial disclosures or conflicts of interest to report. Next slide, please. The objectives at the end of these talk is to know testing recommendations for infants born to person living with Hep C, identify those who can receive treatment, identify the different treatment options that we have for the pediatric population, and be familiar with treatment monitoring and what do we mean by sustained viral response. Next slide, please. So let's start with the current testing recommendations for children born to persons living with Hep C virus. So as you know, Tennessee Department of Health was one of the first ones in the country that actually changed how we were testing our kids who were born to persons living with Hep C virus. And after that, also the CDC did change how we're going to test kids. But the most important thing for all us to know is now we don't have to wait. We can actually start testing as soon as they are 2 months of age. And between 2 and 6 months of age, you're going to actually get a Hep C viral PCR RNA or the NAT test, which are the same, especially in those that you know that the mom was actually Hep C positive when she was pregnant and when she gave birth to the baby. Between 7 and 17 months of those who have not been previously tested, the test of choice too is going to be a Hep C viral PCR RNA. And for those who are more than 18 months of age, or 18 months of age who previously have not been tested before, then the test that you're going to send is a Hep C antibody test with reflex with Hep C RNA PCR. So it's important to know that in the past, we usually would wait until they were 18 months to actually test the kids. And so a lot of the time we realized that during those 18 months, a lot of things could happen. Kids could move out of state. Kids could actually follow with different pediatricians. And we would actually lose follow-up on these kids. So one of the main reasons that early testing has been great for all our children is because now we can actually test sooner, diagnose sooner, and have those kids in the system so no one is getting lost for follow-up, and we can also treat them. Next slide, please. So the main questions that we get from the pediatric care providers is we test a kid when he was 2 months old, 4 months old, 6 months old, and they tested positive. So what can we do? What do we have to do? Do we have to treat it now? Do we have to wait? What do we do to take care? And this is actually very simple because what you're going to do is you know that if you tested that kid and the test was negative, perfect. Nothing else for you to do. You don't need to retest when he's 18 months. You know that you already did that Hep C PCR RNA and that was negative. And so you will continue with his regular well child care. You will document that the test has been done and it's negative. And in those cases where the first test comes back positive and he's 2 months age, you're going to make sure you continue to keep providing the appropriate care of well child care visits per the AAP recommendations. That means that during the first 2, 4, 6 months, and then 9 months and 12-month-olds, he will continue with his yearly checkups and he'll get his vaccinations as expected. Again, you're going to continue 15-month-old, 18-month-old, and then yearly visits. This is not going to change at all. You are not going to have to actually get to see those patients more frequent than what usually the well child care appointments are recommended. The important thing about knowing that this kid has already been tested, and if it's positive, is that we're going to be able to make sure that when he gets to 3 years of age, which is the one that is currently recommended to start treatment per the FDA, is that we actually can know that he is in the system, right? So when the most common questions that I say, you're going to keep providing the normal care that you'll do. You're going to continue with the well child care, and you're going to make sure that kid gets all his vaccinations according to what is recommended. Next slide, please. You're going to do yearly routines. So this is something that usually will be a little bit different. And most likely the first set of labs that this kid is going to get is around year one, when you will get ALT, AST, complete metabolic panel, and total bilirubin. These are just part to make sure we're looking at the liver function and we're assessing to make sure that there's no disease progression. Now, something that it changes between the adults and the children's is that usually we don't see severe liver disease in children who test positive for Hep C. It actually takes about 20 to 30 years to start changing or start seeing changes consistent with severe liver disease or advanced liver disease. But we want to monitor these kids, especially because you want to make sure you're not missing anything else that could be affected the liver health. Next slide, please. And we talked about vaccinations a little bit, but this is going to be very important. Especially, you're going to have to talk to the parents about the importance of actually Hep B vaccination and Hep A vaccination, because we really want to make sure we prevent hepatitis or other types of hepatitis, because we don't want anything else to be affecting that liver or making that liver sick. So it doesn't mean that they're going to get any extra doses of the vaccines. It's just that we're going to have to follow up the immunization schedule as normally you would do. And they will get their Hep B vaccinations at birth, the second dose between 1 and 2 months, and the third dose at 6 months, as well as his Hep A vaccine, which usually we give it around a year of age. And then they get the 2 doses series. So this is going to be the most important thing to talk to the parents about the importance of vaccination, especially Hep A and Hep B vaccination, in order to prevent these infections. Next slide, please. Now, what happens next, right? We've talked about it. We check that kid. We continue to doing the well child care. We are bringing kid in yearly visits as well with the well child to obtain liver enzymes, a complete metabolic panel. So what happened with that kid that you tested with a Hep C pcRNA before age 3? So at that time, you're going to have to confirm when he turns 3 if he has a chronic hepatitis C. And so at that time, you will actually retest it with a Hep C PCR RNA before beginning treatment. Also, if that is positive, you can actually get a genotype at that time, which is going to be useful in order to decide which treatment the patient should qualify for. And these can be as early as age 3. So most of the time when we are saying we're going to repeat, it's going to be at that 3-year-old well child checkup, then we'll repeat the test. And if it continues positive, then we'll definitely start planning for treatment right away. Next slide, please. So serial testing for Hep C, right? That's another very common questions that we get from pediatrician. Do we need to be checking every year? Do we need to be checking every time they come for their 12 well child checks? And the answer is no. There is not always required to do that, but there could be certain exceptions. One is if you notice that the liver enzymes revert to normal for more than 12 months in those kids who had elevated liver enzymes, then it may be actually worth to repeat that in order to see or evaluate if there was a spontaneously clearance of the Hep C infection. And then the second exception that we already talked about it is when they reach the age of 3, and you want to confirm if there is a chronic Hep C infection, because you want to have that information in order to proceed with treatment. But otherwise, we usually are not recommended to obtain serial testing for Hep C at this time. Next slide, please. So who do we treat? And so that is kind of one of the most wonderful things that have happened to the pediatricians who are treating Hep C. We don't have to wait anymore. We can actually start treatment as soon as they are 3 years of age, and with obviously with a confirmed Hep C infection. But we really don't want to delay care, especially because we have options in the ways that kids can take the medication, and we want to make sure we start treating the Hep C and eradicating in order to prevent progression of disease. Next slide, please. So what do we need before treatment? So we talked about that we confirmed the diagnosis of Hep C. We repeated that Hep C. We got a genotype, and we know that we are going to be ready to start treatment. So things that you're going to be required as a primary care provider or as a healthcare provider is that one, you're going to have to educate the family about how you're going to administer the medication, the importance of adherence to the medications. What does it mean about prevention? And the most important thing is you're going to have to talk to the family that treatment for Hep C does not prevent reinfection, as that is a common thing or a common kind of a myth that the family feels like, okay, if he gets treated for these, then he can never get it again. And so you're going to have to educate the family, have an office or a telehealth visit where you're going over this part of the education. You're going to have to look at potential drug-drug interactions. What medications are the patient taking? Most of the time, most of the common medications in children that you're going to have to assess, could there be a drug-drug interaction? It's going to be PPIs, antacid medications, seizure medications, allergy medications. You're going to have to go over the list of medications that that patient is taking in order to see whether there can be any interactions with some of the direct acting antivirals that we're going to use. You're going to determine a fibrosis 4 index and a CTP score in that child. Next slide, please. You're going to have to get a complete blood count. We're going to look at their hemoglobin hematocrit. We're going to repeat again that hepatic function panel, ALT, AST, albumin, total and direct bilirubin, and an INR. This is going to help us to actually calculate our CTP scores, among others. And the glomerular filtration rate is something that it's kind of more oriented for adults. In children's, it's not something as necessary, and we're not doing it as much. Now, you're going to have to get that Hep C viral load. And insurance is going to ask you to document, and it's going to help us also to see where we start. You're going to get a HIV antigen antibody testing, a Hep B surface antigen, and a genotype. As we have discussed, these are going to be forms of screening too. There sometimes can be episodes where kids can have HIV co-infection or Hep B co-infection. So definitely we want to make sure we're screening for this. Genotype that will be requested by insurance or different programs in order to start treatment, and as well as to choose which medication depending on the genotype we can use. Now, the good thing that we have now is that we have 2 good medications that are polygenotype. They're going to treat all the genotypes, and one of the other medications does not treat 2 of the genotypes. So that's why the genotype is going to be so important to know. And the most important thing is liver biopsy. It's not required. We don't have to delay treatment on these kids because a liver biopsy is not going to be required. Yes, and we'll talk a little bit about that. There are going to be some special cases that if you are suspecting that the child may have cirrhosis, we're going to have to do a little bit of more digging. But a liver biopsy, usually for that typical patient that presents with a perinatal infection, a liver biopsy is not required and should not delay treatment for those patients. The most important part of these is that we want to make it easy. So primary care providers, healthcare providers can actually treat without delaying the process of having to send the patient to a subspecialty consult that it can take up to 6 months in some cases, when we can actually start treatment right away as soon as we have all this information. Next slide, please. So as we talk, there are going to be certain factors that we're going to evaluate for treatment, right? We talked about the Hep C viral load. We talk about the genotype. We talk about the Hep C serologies and liver fibrosis. We're going to look at the age and the weight of the patient. We're going to look for the medications. And now I have added here, anticoagulants, HIV medications. But to be honest, most common medications that we tend to use in children are going to be those for heartburn and seizures. So those are something that you're going to have to be mindful about. We're going to have to fill out an insurance formulary that is going to help us see meeting up all the requirements so the medication can be covered by insurance. And we're also going to have to discuss about the patient preference. Most of the time when we're trying to initiate treatment at 3 years of age, we're probably going to have to deal with the fact that that child may not be able to swallow pills. But we have now the presentation of pellets that can actually be given to the child, and it can be mixed with certain foods in order for him to actually take them. You may have adolescents who actually are going to prefer the pill, or I also have some adolescents that tells me I cannot swallow pills. So we're going to talk to that about the patient, about their preference regarding medications. I have to be honest, I've had one adolescent who said I cannot swallow pills, and we had a lot of issues with the insurance regarding covering the pellets. So that is actually a kid that we sent to speech therapy to help us, or kind of how to swallow, give him some techniques on how to swallow pills. So sometimes we have to be a little bit more ingenious in those cases where we need to give the medication, but the patient's preference may be another one. Next slide, please. So we talked about what are we going to do, when do we start treatment, and now we start about medication, right? And so as you can see here, we were talking about the different 3 options that we have of direct acting antivirals that we can use. We have a combination of the Caprevir Prevensivir that you can with any genotypes that will do, the duration course will be about 8 weeks. And this is for first time treatment. You have a second option of Sofosbuvir, Velpatasvir, with children with any genotype for 12 weeks. And then you have a combination of Lenacapavir and Sofosbuvir for children with genotype 1, 4, 5, or 6. And that is a total duration of 12 weeks. Now, and this is where kind of it's important to mention. We were saying, you may be asking, okay, if I have 2 medications that are polygenotype, why do I need to get a genotype? Well, in some cases, the insurance may prefer Lenacapavir and Sofosbuvir, and so you may actually want to know if the medication is actually going to be effective. Most of the genotypes that we see in our area, especially in Northeast Tennessee, are going to be genotype 1, 1A. So it's a positive thing because we know we're going to have that medication that's going to work. But this is where the importance of the genotype actually kicks in. Next slide, please. So talking about the options, right? And we're not going to go into detail of the doses, but for example, we talked about Lenacapavir, Prevensivir, which is brand name is Mavyret. The duration is going to be of 8 weeks, total of 8 weeks, and then you're going to have different types of doses according to the weight of the patient. Now, usually we're talking about less than 20 kilograms. You're going to get a dose of 150 milligrams over 60 milligrams, and those who are more than 45 kilograms or 12 years older, you're going to talk about 300 milligrams or 120 milligrams per day. So this is going to be something very important when you're deciding medications. You have to look at the weight of the patient because the doses will change, especially in children. Next slide, please. As you can see here, we talked about Mavyret, which is the brand name. It's pangenotype and covers genotypes 1 through 6. We have the presentation of oral pellets. We also have the pellets too, and you can actually mix this with soft foods that stick to a spoon, peanut butter, jam, Greek yogurt. In some patients, we have even tried applesauce or chocolate sauce for sure. You want to make sure you explain to parents that they don't want to chew on the pellets, that they want to swallow it. Common side effects that we have with this medication usually is going to be headaches and fatigues. Most of the kids will complain the first couple of doses, but then after that, we haven't had many issues with side effects. Sometimes they can complain about nausea or some abdominal pain, but it usually gets better as they continue taking the medication. Remember that they're taking these every day for 8 weeks. Next slide, please. So Sofosbuvir and Velpatasvir. So brand name for this one is Epclusa. The duration is going to be 12 weeks. As you see here as well, we are based on weight. In this case, they're using 17 kilograms as the lowest body weight for the patient, and the doses tend to increase as the weight increases. Again, all these medications are approved for children that are 3 years of age or older. Next slide, please. This one also comes in oral pellets as well. We can mix with or without food. That's a preference of the patient. Same thing, do not chew on pellets. It's a pan genotype, so meaning that it will treat from genotypes 1 to 6. And we tend to see common side effects, again, headaches, GI issues, fatigue. It seems to be more the first couple of days where kids are going to complain more, but usually as they continue on the treatment, the side effects tend to actually decrease. Next slide, please. And finally, we have Lenipasvir and Sofosbuvir, which is brand name Harvoni. The duration time is going to be 12 weeks. Again, we're seeing kind of weight dose medications, less than 17 kilograms, very similar to Epclusa. And the dose is going to increase as the weight also increases. Next slide, please. This one, you have to be mindful that only covers for genotypes 1, 4, 5, and 6. It comes in oral pellets as well, mix again with or without food. Common recommendations, do not chew pellets. And that's one of the most important things that you can actually tell the parents. Some of the kids may think it's candy and start chewing on the pellets, and we don't want that. We want actually them to swallow it. Side effects, very similar profile with the other medications. And again, it usually tends to decrease as you start taking longer the medication. Next slide, please. So what do we do? So we started treatment. We decided we were going to pick 8 or 12 weeks of treatment. So most of the time, we want to maintain a close communication with the families. We want to make sure we're working on adherence, as this is going to be the most important part. We always recommend at least try to do maybe a telehealth or a phone call visit during treatment, just to make sure the families are adhering to the medication and the patients are not having significant side effects. Usually, if you bring them into the office, then we recommend at 4 week when they have started treatment to get a CBC, liver enzymes, and a total bilirubin. If you are concerned that that patient may not be adhering to the treatment, then you can obtain a Hep C PCR RNA. Now, remember, this is an optional test at that time. But what we want to make sure is that the most important thing that you can know about testing is when they finish treatment. So 12 weeks after you have finished treatment, either it was an 8-week course or a 12-week course, 12 weeks after you have, every patient will need a Hep C PCR RNA, because that is what's going to tell us if the medication has been successful and Hep C has been eradicated. Now, there has been some options in certain patients where if it was a second time treatment or if there was concern about adherence, then we can get a Hep C PCR RNA at the end of treatment. But remember, the one that you have to actually get no matter what is that 12 weeks after treatment, because we want to make sure we eradicated the virus. Next slide, please. So the therapy goal, right? We talked about eradicating Hep C RNA, which is predicted by the attainment of a sustained virological response defined as undetectable RNA level 12 weeks following the completion of therapy. And that's when we say, yes, this virus has been eradicated. Next slide, please. So just to give you an example here, we start, and let me see if I can, 1 second here. Okay, I don't know if you can see it, but we want to start at the baseline. We know that the treatment period starts, and then usually either it's an 8 weeks or 12 weeks treatment. We have here in this case, it was the patient was treated for 12 weeks. You want to make sure that 12 weeks after, in this case, because it was a total duration of 12 weeks, you are going to repeat that Hep C PCR at the 24-week mark, where we expect that the levels are undetected. Now, something that is important to mention here, and that's why we were talking about those that you are concerned about adherence, that even after starting treatment, 4 weeks after starting treatment, we tend to see already the levels go down to undetectable. Now, this does not mean that you have to stop the medication. You want to make sure you end the treatment. And then when you get that sustained virologic response, 24 weeks, then we can definitely say that virus has been eradicated. Next slide, please. So when do we need to refer? And that's the other questions that usually will get asked, right? What do I do with this kid? And I always say, to be honest, right now, treating Hep C may actually be easier than treating asthma because we have come up with protocols where we are monitoring patients. We are have straightforward recommendations on when to test and a treatment available. So, but there, of course, are going to be some cases where you need to refer because either this patient may be presented with decompensated cirrhosis, there may be a moderate or severe hepatic impairment with CTP scores of class B or class C. And when you actually have treated a patient and it has failed multiple times or it has failed treatment multiple times. So yes, there are going to be certain occasions or is there's comorbidity that you are afraid that it may be actually impacting the liver function. So yes, those are the cases when absolutely you will need to refer the patient. But otherwise, we want to make sure we start treating these patients right away. Next slide, please. And so when we're talking about decompensated cirrhosis, we are pretty much saying that it's symptomatic patients that are actually in liver failure or have liver failure associated mortalities. These patients can have findings of ascites, of hepatic encephalopathy. They can have low albumin, elevated INR and PT time, elevated bilirubin. And of course, you are going to calculate or predict outcomes only in the patients with cirrhosis. So if you know a patient has decompensated cirrhosis or liver disease or cirrhosis liver disease associated, then of course that patient needs to be referred. Most of the time, we're actually referring these patients to quaternary centers that have a liver program or liver transplantation programs as well. Next slide, please. The CTP score, it has been developed for predicting the mortality in a patient. Now, it's used for assistance with predicting prognosis and liver dysfunction, and you have to kind of look at if the patient is presenting any encephalopathy, ascites, what's the level of the bilirubin and the albumin, and then INR, which is important. So if you're talking about class B between 7 and 9 points and class C between 10 and 15 points, then definitely that is a patient that you want to refer. Ideally, if you have a local pediatric GI hepatologist doctor, absolutely. If you don't, then you can always refer to a quaternary center with a liver program, because those are the patients that sometimes may be even placed in transplant lists and things like that. Next slide, please. Now, treatment resistance. So with treatment resistance, it's one of the things that in clinical practice, sometimes we have to modify, and it can affect the duration of therapy or the use of other medications. Now, unfortunately, really looking for resistance at this time varies by patient and the DAA regimen. And some places, actually, it's hard to find how can we actually test for resistance, right? So this is going to be something important that you have to evaluate if a patient has actually finished the first treatment and was compliant and was adherent, and then there is a second treatment round and he fails, that's when you want to refer it, because we want to kind of dig a little bit more about potentially what's going on with this patient that is showing resistance, and also step up on treatments. Now, a lot of the time, important things to do is actually have that discussion with the family about the adherence is important. I've had some families who say, oh, well, the kid was taking the medication 2 or 3 times a week. But we were trying to give like a higher dose. And I'm like, that's when you have to actually have a better communications with the family, follow up more closely, because sometimes it can be regarding how are they giving the medication, how frequent are they giving the medication. So those are very important things to talk about initially when you're going to start treatment in order to actually even prevent resistance in the future, correct? Next slide, please. So when we do that, and we talked about the counseling, right? We want to make sure the parents understand this clearly, because when we start treatment in children, we're starting so early that that child may never know until he's a little bit older that he had Hep C. So what I always explain to my patients is that reinfection is possible, that reinfection can happen. Once the adolescent starts becoming sexually active, using IV drug use, then absolutely reinfection is possible. That the treatment, that despite the fact that they're being treated, that does not prevent reinfection. That we don't have a Hep C vaccine. And that is something that I explain them a lot, because especially we're doing Hep B, Hep A vaccinations. But I explain them that we don't have a Hep C vaccination, that we have great treatment and we can eradicate it, but that these does not prevent reinfection. And that from now on, the test of choice for any patient who has had Hep C and who has tested positive and treated is going to be Hep C RNA PCR, because their antibody, it's always going to be positive. So I explain to the parents this because I feel it's important for them as that kid is getting older, becomes an adolescent and then an adult, to make sure he knows what's going on. And especially, we talked about more about how we can actually prevent and how we can prevent reinfection, and about kind of education on safe sex practices, not using IV drugs or not using drugs at all. Next slide, please. And educate, educate, educate. As I was telling you, most of my patients are little, are 3 or 4 years old. Now they're coming even younger because of their age of testing. But I always tell the parents that they should not be avoiding any activities. They should not avoiding not going to daycare, not going to schools. That they don't even have to actually disclose this to the daycares. That the kid can actually do all the activities that he wants. That he should just take universal precautions. That if you're not going to share toothbrushes, razors, nail clippers. That if there is any blood, you'll use gloves, you'll use protection, you use bleach. So I tell them you're going to have to use universal precautions, but we should not limit the activities of children because of Hep C. Next slide, please. Questions right now as we were discussing this.
Please feel free to come off mute or even drop your question in the chat. Okay. Oh, someone did post a question in the chat. So what happens if a child actually chews the pellets?
Well, and I'm going to let Dr. Allen also go in, but from a clinical practice, I've had complaints that the pellets are actually very sour, and the kids complain and then has this sour taste and then start throwing up. So that's something that I've seen on the clinical experience of why we want to actually make sure we avoid them chewing the pellets. And Dr. Allen, I think he can kind of give a little bit more also about that.
Yeah, that's the main thing that I read when researching pediatric pellets is that, yeah, they can be very bitter or very sour. And there's also can be disruption in absorption. If they're crushed or chewed like that, the pellets won't get absorbed correctly when they get down into the stomach and into the intestines where they're supposed to absorb correctly if they're already crushed or been manipulated at any point. So that's all the more reason to tell them to just find a food that they can swallow whole with the unadulterated or undamaged pellets in there. So that would be a great question. I'm glad that was brought up to mention why there is value and why we tell them don't chew it. So yeah, two reasons: bitterness and potential messing with absorption.
And
There's an,
I
oh,
saw,
go ahead,
yeah,
Doctor.
I'm seeing a question about how common is cirrhosis in children. Not very common. So we are talking, and in the US, we have few cases of cirrhosis in children. I think we're talking about there was one about 3 to 5 children between the ages of 5 to 10 years old who developed cirrhosis, and there were other actually comorbidities associated with that. So they were not exactly only blaming Hep C for that. I have to be also mention this because we're seeing it more in our adolescent populations who have Hep C and who have actually fatty liver disease or are obese, then that can actually increase the risk of cirrhosis. But about numbers, we really don't have specifically the incidence or the prevalence of cirrhosis. We can tell you that the cases that we've had are case reports where they are talking about 6, 7 patients. But even in the world, at cirrhosis, I think there was a new study back in 2019 that said that the prevalence was 219,000 kids in the world. And that was not only associated with Hep C, but all etiologies for liver disease. So regarding cirrhosis associated with Hep C, very, very uncommon. Not